Welcome, everybody. My name is Marty Mascari. I am with the North Central Texas Area Agency on Aging and the North Central Texas Aging and Disability Resource Center. Both of those are under the umbrella of the North Central Texas Council of Governments. We are in the greater Dallas-Fort Worth, Texas area. And I must note, I'm a contractor with them, but we are blessed once again to have our partners at the James L. West Center to talk to us today about depression versus dementia. But before we get started, we're going to, first of all, I'll say when we have a lot of people on, and so we do all these in webinar format. I see a few of you have raised your hands. Please put any comments or questions you have in the chat or the Q&A, because we will not be calling on people or opening up mics. It's just too hard to handle when we've got 200 people plus on the webinar. So I'm going to turn it over to Jamie Cobb-Tensley to talk to us first about CEUs. The James L. West Center is gracious enough to provide the CEUs today for this presentation.
Thank you, Marty. Welcome, everyone. We are happy to provide CE credit for social work, licensed professional counselors, nurses, and anybody who wants a certificate of attendance. Marty will send out a follow-up email in the next day or two, and there will be a SurveyMonkey evaluation in that email. We ask everybody complete that evaluation because we really do appreciate feedback from everybody. But if you want CE credit, it is required that you do the evaluation. And if you'll please allow us 3 to 4 weeks, maybe closer to 4 to 5 weeks, then we will process all of those CE credits and get those out to you through your email. Thank you.
Just to let you all know, it is a tedious process. You know, we have to match up the evaluations with the Zoom report and to verify that you've been on for the whole time in order to then generate the certificates. So it's a tedious process. So please be patient with us. If it's a month or more after this week, please feel free to email me and we'll look into it. But please give them the time to do that. We also ask, if you would, there's a Google survey that should pop up as an opportunity for you to complete as you close out of Zoom today. There will also be a link for that in the email that I send out to you, the follow-up email. Please complete that for us. That gives us the information we need to report back to our funding sources on the goals and objectives we set forth when we applied for the funding to put on these webinars. So Jamie, I'll let you introduce Holly and we'll get rolling.
To introduce Holly. I'm happy to introduce Holly. She is the best person to talk today with us about depression versus dementia. Holly is a licensed professional counselor and a dementia care expert. So I will turn it over to her to get us in this content. Thank you.
Thank you, Jamie and Marty. Glad everybody's here today. It looks like we still have folks hopping on, but we are going to get started because we've got two big topics to talk about, and I am excited to be able to bring this to you today. I spent most of yesterday afternoon updating this program because things change and new statistics come out. And there's actually the new, the State of Mental Health in America 2023 has recently come out. It is put out by Mental Health America. I'm going to be giving some statistics specific to Texas, but you can look up your state, and I'll actually have Marty or Jamie type that in the chat. Mental Health America, the State of Mental Health in America 2023, and you get a whole, well, you can't see it because I got my background on. I ran it off. It is 38 pages, covers every state. It's really interesting, and it's especially interesting when you track it from year to year. So we're going to talk about that coming up pretty quick. Here's some information about us here at the West Center, like Jamie was mentioning. There's my information and our objectives for those of you that are getting your CEs or certificate of attendance today. What we're going to do is we're going to take the topic of depression and the topic of dementia, look at each of them separately, and then see how we now have proof that people who have untreated lifelong depression, it is actually changing the brain chemistry, and down the road, it's turning into dementia. We're going to look at some scans even. I found some great graphics to go along with this, but we're going to start with depression. We're finally starting to talk about depression, but what I hate as a mental health professional, first of all, I hate that term mental health professional because we hear that word mental illness and nobody wants to have a mental illness. And so in my field, and those of you who might be LPCs, who LMSWs, LCSWs, we really prefer to use the term brain health rather than mental illness. Nobody has a problem telling you about their cardiac health, sharing their high blood pressure medicines or their cholesterol medicines. But nobody wants to talk about their antidepressants or their anti-anxiety meds because it falls under mental health. It even technically falls under a mental illness. What if we called it brain health? So I want to start with that. Now, when I'm pulling statistics, you're going to see me use the term mental illness and mental health because unfortunately that's what we still call it. But just a thought for all of us, just like with dementia now, we don't use the word behaviors, we use challenging expressions. So let's look at depression. It's very serious and it's common. And in the last 3 years since the pandemic, we're going to really see what has happened to the numbers. It's treatable. We're going to look at statistics about that also. And there's different ways to treat it. We're going to look at the symptoms of depression and dementia. And I'm going to give you a lot of resources as we go through here. The first one on this page you'll see is psychiatry.org. Great place to go for information, for statistics, or just for articles. So let's look at these brand new statistics. Again, if you are interested, it's called The State of Mental Health in America, and it's put out by Mental Health America, and you can find your state. But I want us to see some things that's going on in Texas for those of you that are here. Texas is number 3 in adult prevalence of any mental illness. We were number 2 last year. Number 1 is Georgia, by the way. Texas is number 2 in adults with substance use disorders. And if I remember right, Georgia was number 1 in that one as well. Yes. Texas is number 3 in adults with serious thoughts of suicide. Texas is number 28 in youth with at least one major depressive episode in the last year. That has changed. I believe we were 15 last year. Texas is number 12 in youth with substance use disorder in the past year. And then this one, again, as a licensed professional counselor, look what this statistics tells us. In Texas, the ratio is 760 to 1 for a mental health worker. So for me, that means if I were to hang a shingle and see clients every 55 minutes, my caseload could be 760. That doesn't even make sense. So for every 760 people, there's one healthcare worker, trained healthcare worker in Texas. And you can get your state's statistics from this pamphlet. Again, The State of Mental Health in America, 2023. Now here's some 2022 statistics, and some of these again came from Mental Health America, but they don't have the 2023 out yet. But people go online and look for screenings that they can do. Depression screens, anxiety screens, ADHD screens. There's all kinds of screening that we can do online, which is good. It's a good thing that we've kind of got that at our fingertips. And as they track it, let's look at some of these statistics. 138% increase in online anxiety screens from 2020. And 2020 was the shutdown. So here we are in 2023, and it's gone up 138%, a 62% increase in online depression screens. And then 78% of those who took the screens scored between moderate to severe for anxiety. and or depression. 35% of those that were screened said they had serious thoughts of suicide. And 48% of youth, 11 to 17 screened, reported thoughts of suicide or self-harm. Now, let me tell you this, that is way, way down from last year. Last year, I believe that was about 7, I know it was in the 70s, 75. So even though 48% is still a really high number, it is significantly lower than it was last year. I think as we are getting into what we're calling that time of reconstruction, I refuse to use the word new normal. It's reconstruction. We're figuring it out. We're getting back to some sense of normalcy. And then this number also kind of took a big dive. 49% said loneliness and isolation contributed to their mental health concerns. And that also was about, I believe it was 79% last year. So that's a big change just because times are changing. Now, these are the main concerns that are sending people to counseling right now. These are the main concerns that are also sending people to these screenings online. Now, I bet everybody's going to be able to answer why in the world are 60% of the people having issues with body image and self-image. We've got social media to blame for that. But it's driving 60% of the people to therapy or looking for help online. Because all they're seeing are people posting the perfect world. And especially with our young people who don't understand that that's not reality. And they're developing issues with body image and self-image. 51% of folks are looking for help with relationship problems. 49% with loneliness or isolation. 42% with school or work problems. 20% with financial problems. That's actually down. 16% with grief or loss of something or someone, keeping in mind that grief just means loss. It does not necessarily mean death. It means that there's been a loss of something or someone. And then 10% of the people who are seeking counseling or seeking help online, it's due to abuse or violence. Next, I want to show you a very basic patient health questionnaire. And this is a great way to get started when we as professionals are talking to someone or for ourselves. Now, one of the ways that you can answer this is not at all, several days, more than half of the days, nearly every day. And you're supposed to think about each of these over the last 2 weeks. So I want you to take a minute and read through this. Look at the changes we're looking for, changes in sleep, energy, eating, feeling bad about yourself, concentration, the way we move or speak, thoughts of harming yourself, thoughts of being better off dead, little interest in doing things that we normally take interest in, feeling down, depressed, or hopeless. Those are some of the things that we look for. But I want us to actually look at the symptoms of depression. So most people, and if I were to ask you, which I'm not because we're over 230 people, but if you just go up to your regular person and say, tell me about depression, what are signs and symptoms of depression? Most folks are going to give you the very first one there, sadness, empty, mood changes. A person can be diagnosed with different types of depression. We're going to talk about the different types of depression and not be sad. There's lots of other signs and symptoms of depression, and it affects different people in different ways. So take a look at those. And what I'm going to encourage you to do, whether you're a family caregiver or a professional caregiver, I hope that as you get access to the slides, and Marty has put them in the chat, and then they'll be sent out again. Take a highlighter, run this page off, and highlight each of those that you have experienced in the last 2 weeks. In the last 2 weeks. It's a good tool to use with others as well. Now, you've got to be honest on it. It's just for you to look at. Because an awful lot of people, what I've experienced is they'll look at that and they think, well, that's just because I'm a caregiver. I only feel this way because exactly. And being a caregiver, especially a caregiver of somebody with dementia and depression, hand in hand. Take it very seriously. Now, I want to talk about depression in older adults. And this comes from the Mayo Clinic, and I've got it in bold. Depression is not a normal part of growing older. Just like we'll find out, dementia is not a normal part of growing older. What happens, though, in older adults many times is they don't seek help. There's a stigma. Again, when we use words like mental health, mental illness, and depression fits under that umbrella. But look at some of the symptoms in older adults and look what's right there. Memory difficulties, personality changes, wanting to stay at home. This is starting to sound like something else we know. This can sound a lot like dementia. Depression can mimic dementia. But as we're going to see in a couple of slides, we can treat depression. There are treatments. We can alleviate symptoms. And somebody who's in a very deep, dark depression, if they receive treatment and they stick to their treatment plan, those memory difficulties can go away. It's a reversible memory loss. Or when it's an actual dementia, that is not reversible. But it's very, very normal to start having memory difficulties when somebody is in an extreme depression. Now, there are many different types of depression. And again, those of you who have studied our favorite book I have here, the DSM, those of you who had to take those classes like I did, interesting book. I just put on here the 5 that we tend to see the most often. So that persistent or chronic depressive disorder. Notice that for somebody to get diagnosed with this, it lasts for a minimum of 2 years. Now, it's a major depression and it comes in bouts. So it can almost feel like it comes and goes. There's periods where the symptoms are less severe, but they're always there. But they're not as severe at times. You may have heard of postpartum depression. That is a major depression that starts during or after delivery. Extreme sadness, extreme anxiety, and exhaustion. It is not what some people call normal baby blues. It is normal to have some baby blues. It is not normal to have postpartum depression. We need to treat that. Seasonal affective disorder. We were just talking about this the other day. When that time changes and it starts getting dark at 4:30, 5 o'clock, a lot of folks will go through seasonal affective disorder. Now, with that being said, you can also have seasonal affective disorder in the spring and summer. There are those who also have it in the spring and summer. It's most common in the fall and winter where there's less natural sunlight. Weight gain, increased sleep, starting to withdraw. I've got a happy light sitting on my desk right here that I use in the fall and the winter. I just leave it sitting out year round, mimic sunlight. Major depressive disorder, you may have heard of this one. This is clinical depression. This is symptoms most of the day for 2 weeks. Here's the key, that interfere with the ability to work, sleep, study, eat. You can have one episode during your lifetime, or you can have multiple episodes during a lifetime. Many of us had a major depressive disorder episode during the last 3 years. Post-COVID depression, real thing. I had it. Post-COVID depression that lasted for months, and was interfering with work, sleep, study, eating, all of that. Major depressive disorder. And again, it can last for several months, and that may be the only time you ever have it, or you may have several episodes over the course of a lifetime. And then there's situational depression, which I think we have all experienced situational depression. It's very normal to experience situational depression. Let's think of reasons we might have a situational depression. Loss of a job, loss of a relationship, death of a loved one. It's where grief comes in waves to where it almost knocks us over. We can barely keep our head above water. But during that situational depression, our self-esteem is usually maintained. A pandemic, situational depression. There's all kinds of reasons we can have a situational depression, and it may last a while. Our loved one has dementia and I'm their primary caregiver. Situational depression, because it's not something that's going to go on forever, even though it feels like it is not. Let's look at risk factors for depression. I want to point something out here because I saw how many of you were logging in, and a lot of you had a lot of letters after your name, just like I do. Healthcare professionals are at a very high risk for depression and suicide. I want you to think about this. In 2020, some of y'all may remember those first programs we were doing, and we talked about in 2020, 31% of all suicides were healthcare workers. 31% of all suicides were healthcare workers. Last year in 2022, over 200,000 people left the field of healthcare. We don't ask for help. And why do we not ask for help? Well, if you saw my wall back here behind me, which you can't see, I've got all kinds of diplomas and certificates on that wall. I don't need any help. I'm the one who gives help. I've got all the certifications. I don't need any help. Do you know the highest risk of drug and alcohol-induced dementia are healthcare workers? Because healthcare workers many times will find other ways to deal with our own depression and anxiety. Something else I want you to think about while you're looking at these risk factors is what depression can look like, the difference in women and in men. In women, many times depression does show up as a sadness, even a feeling of worthlessness. And there's many times a lot of guilt associated with depression. And in men, we may see overly tired, irritable, and even anger as signs of depression. So some differences in men and women. Notice on genetics, about a 40%, if there's a history of depression in the family, 40%. Biological, talked about men and women. Chemicals in the brain, hormonal factors. 1/3 of women will have a major depressive episode at least once in their life. I think that number's low. Environmental factors, psychological factors, stress, or trauma. And this can be trauma that currently happens And we now know, as we study and we learn more and more about trauma-informed care, that trauma triggers trauma. And what we just went through in the last 3 years has been a trauma. And for many of us who have trauma in our past, it went back and it ignited old trauma that we thought we'd dealt with, that we thought we'd compartmentalized, that we thought we'd put away. But trauma triggers trauma, and it will send us back into old ways of dealing, old, unhealthy coping skills. Look at the sales of alcohol and what happened to them the last 3 years. How many people went back to smoking who had given up smoking? We go back to what we knew. This is how I coped when I was 20. I'm in a tremendous amount of stress. I believe I'll eat. That's mine. We go back and we do what we were taught or what we learned to do, because for most of us, no one taught us emotional hygiene. Somebody taught us physical hygiene, how to take care of our body. But did anybody teach you how to take care of your emotions? Or did you learn from watching people who maybe weren't doing a great job at taking care of their own emotions? We're going to look at the next slide at physical illness and how that's related to depression. These are some brand new statistics also that I found yesterday on the National Institute of Mental Health. Depression often coexists or co-occurs with other illnesses and medical conditions. They're tracking them now so that we can look at these statistics. I love being able to look at statistics and get an idea. 25% of those that have cancer will also experience depression. Notice that 59% of coronary artery disease. Let's think about why that is. Coronary artery disease oftentimes is what's diagnosed before the stroke, before the heart attack. Somebody's telling us to make some lifestyle changes that we don't want to make. Somebody's telling us we've got to change our diet. Somebody's telling us we've got to stop smoking. Someone's telling us we've got to stop drinking. Depression, coronary artery disease. 50% of people with HIV, 50% with Parkinson's, 33 to 50% with eating disorders. I think this one's low. 20% with substance use disorders, 33% with diabetes, and 20% with PCOS. PCOS is polycystic ovarian syndrome. Polycystic ovarian syndrome. It used to be called Stein-Leventhal syndrome. And it is causes young women to have a very hard time getting pregnant and is a difficult condition to deal with. Depression in the elderly, again, the latest statistics, 7 million adults aged 65 and older are affected by depression. And then look at this one, especially those of you that are caregivers, adult children. A survey of adult caregivers found that 40 to 70% of them have clinically significant symptoms of depression. Especially in adult children, we see people like myself. I still work. I am married. I am a mother. I am a grandmother. I have all these different hats that I'm wearing, but I'm a caregiver too. It doesn't end at the end of the day when I leave work. In one way, it's just beginning. How do we get diagnosed? Diagnosis of depression. The symptoms need to be present for at least 2 weeks, and most of the time by the time someone talks to a doctor, it's usually been much longer than 2 weeks. And we need to be very honest when you go in and talk to the physician. You want to start with your primary care physician. They're going to do a diagnostic exam. They should do an interview, a physical exam, and then they need to do some extensive blood work or lab test. because they want to rule out other health conditions that can mimic depression. Things like thyroid disorders and vitamin deficiencies can mimic depression. The doctor should also really do a good job at exploring medical and family histories. You can also see a psychiatrist. Now, this is like a primary care physician, but it is somebody who specializes in mental health. They can perform therapy, they can recommend therapists. There are licensed professional counselors like myself. There's licensed clinical social workers, licensed master's level social workers that can administer and perform depression scales, depression inventories, use assessment instruments. There's a psychologist that can do in-depth psychological testing. Now, I want us to talk about treatment. And again, these are the latest statistics from the National Institute of Mental Health. All depression can be treated. Now, I know you've heard of treatment-resistant depression. That is a very real thing. That is real. We all came to know about it because of Naomi Judd. She wrote a book about it, and we know how her story ended. But she, in her book, also says that when she followed her regimen that she was supposed to follow, she had some symptom relief. Hers never went away 100%, but she would have some symptom relief. Now, 80 to 90% of the time, depression can be cured. That's a high number. And another 20% of the time, we can see a reduction in at least some of the symptoms. But what happens is about 50% of the time, people are non-compliant. Because by the time we get to the doctor, I need it fixed now. I want that pill to work tomorrow. I want to go to one therapy session and be better. And it doesn't work like that. Depression didn't come on all of a sudden, and it doesn't just go away all of a sudden. The earlier we can treat it, the more effective the treatment will be. And then this last bullet point is so important for us to hear, for everybody, professionals and families. No two people are affected the same way by depression, and there is no one-size-fits-all treatment. It may take time and trial and error to find the treatment that works best, whether you're using medication or you're using other forms of treatment. We're going to start by talking about medication. And again, stigma. There is a stigma with an antidepressant. But now that we know, and we're going to look at a slide that shows us that there's a link between untreated depression and dementia. And there are many, many different kinds and types and strengths of antidepressants. They're not habit forming. They are not uppers. That was something that got started back in the 90s when people were talking about Prozac when it first came out. It helps our brain chemistry. It helps the brain improve the way chemicals that control mood are used, but it does not do it overnight. Typically, after 2 to 4 weeks, we start seeing some symptom improvement. But usually it takes 2 to 3 months to get the full effect. And again, when somebody is very, very depressed, many times they are not compliant with what the doctor's asking them to do with their antidepressants. They'll either over-medicate, under-medicate, not take it at the same time every day because I need it to work right now. Most of the time, it's going to be recommended for at least 6 months. And some of the symptoms that are usually improved within those 2 to 4 weeks are sleep, which is huge, appetite, and concentration. And if those 3 things can start to improve, we're starting to turn the corner with depression. We don't ever want to stop taking an antidepressant, without the help of a doctor so that we titrate off of that. Now, there's also psychotherapy, talk therapy, counseling, whatever you want to call it. And the most common type or kind that you may have heard of is CBT, cognitive behavior therapy. This focuses on, I use this with my support group every week. We reframe situations. We problem solve. This is a big part of being in a support group when we have a loved one with dementia. We're problem solving. We're focusing on what remains rather than focusing on what is gone. That is cognitive behavior therapy. Cognitive behavior therapy helps us recognize negative thinking and then reframe. It helps us respond to challenges in a more positive manner. Very useful. There's interpersonal therapy. It is usually 12 to 16 weeks. It can focus on symptoms, relationships. There's problem-solving therapy, helps manage negative, stressful events in life, focuses on a wide range of difficulties. A lot of folks will go to this whenever they are having the situational depression. I personally use a lot of narrative therapy, where you use a person's story to build their therapy. There are different types of therapy. These are just some of the most common. There's a lot of them out there. And there's other interventions for depression. And if we're using an antidepressant, we find ourselves with a good counselor or in a support group, and then we add some of these other things. And I know, believe me, I know, sometimes the last thing we want to do when we're depressed is exercise. Are you kidding me? That's the last thing I want to do. But it can make such a difference. If somebody can commit to 15 minutes twice a week, just a little bit, a small goal to be able to check off and say, I accomplished that. That goes right with the next one, setting realistic goals. Remaining social, having someone to talk to that doesn't try to fix it. Many times we try to take these issues to our spouse, and our spouse wants to help us and they try to fix it, and that isn't what we need, because maybe it can't be fixed. Maybe we just need to be heard. Educating yourself about depression, finding out more what you're doing right now, breaking large tasks into small ones, setting those priorities, working on sleep and diet. And then it is so important to not self-medicate. Alcohol, drugs, food, shopping, pornography. There's all kinds of ways that we self-medicate. Take my mind off of this and put it somewhere else. Keep in mind also that our goals have to be gradual and not immediate. We want it to be immediate, but they have to be gradual goals, but they need to be realistic goals. What we can do to help someone who is depressed. Listen. Validation therapy. Don't ever ignore comments about suicide. Try to get them outside. Sit outside, take a walk, sit on a bench, be out in nature. Help them adhere to a treatment plan. Offer them rides to therapy. Go pick up the prescription. Join the gym with them. Help them keep in mind time and treatment and staying compliant with the doctor's plan, and be there with them when they slip. and be there to lift them up when they fall and to walk alongside them. I've put some great resources here, the National Institute of Mental Health, and this is where I got a lot of the statistics. Behavioral Health Treatment Service Locator, your primary care physician's office, the National Suicide Prevention Lifeline, and then on Psychology Today, you can actually go to that website, psychologytoday.com, and they have a tab called Find a Therapist. You can click on that and you can get as specific as you want to. You put in your zip code. You can say, I want a female who practices cognitive behavior therapy who takes Blue Cross Blue Shield, and it'll pull up the people in your area. Let's start to change gears and talk about depression and dementia as we kind of segue into dementia. Here's the graphic I was talking about earlier. Look at how powerful this is. Depression changes brain metabolism and blood flow in that frontal cortex. Look at the difference in the healthy brain on the left and the brain with chronic depression on the right. Now, if that person stays depressed and does not receive any treatment, it's going to permanently alter their brain chemistry. One of the areas that's being affected is the hippocampus. The hippocampus is called, those of you who've studied this, the hippocampus is the memory center. Are you seeing the link now? The link between depression and dementia. Another area that gets damaged by untreated depression is conflict resolution. And what else is up here in the prefrontal cortex? Planning, executive function, all of those symptoms of dementia. Now, the hypothesis is, and the next slide I'm going to show you, shows you how they kind of get to this. Untreated depression leads to vascular lesions on the brain, which leads to vascular dementia. You can see here from depression to dementia, where there starts to be that hippocampus starts to atrophy, increased plaques, inflammatory changes. These are all because of depression. Alterations in nerve growth factors, vascular disease leading to dementia. This graphic came from the U.S. National Library of Medicine. It's a very real thing. Now we know. Now we know. We can't beat ourselves up over we didn't know what we didn't know, but now we know. So let's start looking at dementia. For most folks right now, I want you to think if we were in an open group and I were just asking you as a group, and you don't have to type this in, I want you to just answer it in your head. The first word you think of when you hear the word dementia. First word you think of when you hear the word dementia. And I also want you to think of the age group that comes to mind when you hear the word dementia. So in your mind right now, first word and age group. I want you to think of those real quick. My guess is that many of you said memory loss. They forget. They don't remember. Those are all three the same things, by the way. And maybe 80, 85, somewhere in there. So keep that in mind as we start talking about dementia. That's the typical answers that I get. Some of you absolutely know more about it. But I want you to think of it this way. Dementia is that umbrella term. There's over 35 common symptoms to dementia. We're going to look at symptoms. And dementia can present with no memory loss. it can present with no memory loss. It's coming later. I've got in bold print in that second bullet point, dementia indicates problems with at least 2 brain functions. Notice, at least 2. Typically, it's 2 of these 3, memory loss, judgment, and language. Memory loss, judgment, and language. If it's just memory loss and there's nothing else going on, then many times it's something else. It's depression, it's a vitamin deficiency, it's a thyroid, it's medication interaction, it's malnutrition. There's other things that might cause memory loss. So problems with at least 2 brain functions. Also keep in mind that dementia, the word dementia itself is not a specific disease because there's over 130 different types of dementia. We're going to look at the most common today. It is progressive. It is terminal. It is not a normal part of aging. Just like we said, depression is not a normal part of aging, and it is not contagious. We use this photo a lot. That normal brain on the left weighs 3 pounds. Our brains should be weighing 3 pounds. That brain on the right, that is at the end stage of Alzheimer's disease, the most common type of dementia. Notice the difference. That's a 1 pound brain. What a difference. We cannot expect the person on the right to act or behave like the person on the left. They can't. They don't have the ability. Now, they didn't do anything to make this happen. Why does it happen to some people and not to others? We don't know. We know there's some risk factors. We're going to look at that. But this is powerful when we look at this brain failure, at this brain that's dying, at this brain atrophy. This is what's happening in the brain of someone with dementia. Now, I mentioned those signs and symptoms, and yes, memory loss is listed first because in most people it is what the families will notice first. But after they get educated and they come to some classes or they get in support group and they start seeing some of these other things, most everybody will go, well, I didn't have any idea that changes in appetite or crying or being anxious or having sleep disturbances. I didn't know that that was part of dementia. They've been doing that for years. That started before the memory loss started. Or it may be someone who's well into this disease. They're getting into that moderate stage of the disease and they start having some of these other things, paranoia, hallucinations, destroying property, becoming aggressive. And if we're educated, then we know that this is a symptom of the disease. This is one of the best graphics that we have found to describe dementia being an umbrella term. It is an umbrella term, just like the word cancer is an umbrella term. Under that cancer, there are many, many, many different types of cancer. Under the word dementia, there are many, over 130 different types of dementia. But look at these statistics. The reason you hear about Alzheimer's the most often is because it's the most common. 60 to 80% of all dementias is Alzheimer's disease. So Alzheimer's is the most common form, type, or cause of dementia. Now we're going to see, and if you look at the bottom of that graphic, it says mixed dementia. That is now the second most common type of dementia. And that's when somebody has 2 or more dementias. Most common is Alzheimer's and vascular. You see Lewy body, vascular, frontotemporal, and then other types, which we're going to look at each of these. Again, we said that Alzheimer's disease is the most common type of dementia. Therefore, that's the one we hear about the most often. So I want you to listen to these two sentences because I hear both of them often. One is correct, one is not. My dad has Alzheimer's, but he doesn't have dementia. That's not a true statement because Alzheimer's is the most common type of dementia. My dad has dementia, but he doesn't have Alzheimer's. Now, that may very well be true because maybe he has Lewy body dementia. Maybe he has frontotemporal dementia, but he doesn't have Alzheimer's. Okay. Fourth leading cause of death in people over the age of 65 in the United States. I've added mixed dementia there as the second most common type. That's where there's two or more dementias. Normally, what we tend to see is Alzheimer's and vascular, or we might see Lewy body and Parkinson's. It's anybody that has two or more. There's vascular dementia, and it's exactly what it sounds like. It has to do with the vascular system. The most common cause of vascular dementia, TIAs, little pinpoint, tiny strokes in the brain. This is also the one dementia that can have a sudden onset. All of the other dementias are going to come on over time, years. But vascular dementia can happen after a stroke. Now, vascular dementia is also the one that we do have some control over because look at the causes of vascular dementia. High blood pressure. Now, this is uncontrolled high blood pressure. Uncontrolled high cholesterol, diabetes, heart issues, smoking. Smokers are at a high risk for vascular dementia. Anything that has any type of a disruption between that oxygenated blood going to the brain. In vascular dementia, many times the personality and emotions of the person remain intact for a very long time. And judgment isn't usually affected until much later in the disease either. Because what happens with vascular dementia is wherever the stroke or the blood flow changes took place, that's where the damage is. So it's typically the mildest of the dementias. The other two we're going to look at is Lewy body and frontotemporal that are listed on this page. Now, Lewy body has an average onset in a person's 60s. So we mentioned 80s earlier. In our day program at one time, we had a gentleman that was 47 years old. It's not just people that are over 65. Now, I want you to look at some of the symptoms of Lewy body because it begins with problems of mobility and with falls and with hallucinations. And if you know anything about medicine, you know that sounds a whole lot like Parkinson's. And it presents as Parkinson's. In fact, a person can have Lewy body and Parkinson's at the same time. The treatment for Lewy body is very difficult because if you treat it as Parkinson's, and you give them the medications to help with the mobility and the gait, it then affects hallucinations. And if you give them the medications that usually help with hallucinations, it affects the mobility and the gait. Lewy body is a very difficult one to treat symptoms because that's all we're doing with any of them, honestly, is treating symptoms. The other frontotemporal dementia actually is its own umbrella. There's many different kinds, types, forms of frontotemporal dementia. And it typically starts with personality changes. Because, think about what it's called, frontotemporal, and what is stored in the frontotemporal parts of the brain. We usually see this in much younger people from 30 to 65. It's got a very strong family history. Frontotemporal dementia is about 50% in families where the others are more like 30%. It's also 4 times more common in men. We see those personality changes, judgment, social behaviors affected first. They may start doing socially inappropriate, challenging expressions, flat facial expressions. They don't care. They'll say they don't care. And it will present as an emotional or a mental illness. Because think about it. Somebody's in their 30s or their 40s. They're being socially inappropriate. They're having some personality changes. Why in the world would we think dementia when somebody's in their 30s or 40s? It typically takes a very long time for these folks to get diagnosed. I want us to look at the risk factors for dementia. And again, this is another slide I just updated. And this is from the National Institute on Aging and the Alzheimer's Society, because they've added a couple of things. I was talking to Jamie earlier about what's been added to this list of risk factors. Age is going to be on there. After the age of 65, the risk of developing Alzheimer's disease doubles approximately every 5 years. We've mentioned genetics. It's usually about 30% of the time, except for some specific dementias. Smoking, we've mentioned. Obesity, that sedentary lifestyle. Alcohol use, plaque in the arteries, high blood pressure, there's depression, hearing loss. And what I found on hearing loss, mild levels of hearing loss increase the risk of cognitive decline and dementia. Though it is still unclear how exactly it affects cognitive decline, hearing loss can lead to social isolation, loss of independence, and problems with everyday activities. And it's been moved to the list of risk factors. Sex, we have more women than men who are diagnosed with dementia. Women do tend to live longer on average. They also study estrogen levels over a woman's lifetime. And what they have found in studies is that women who do hormone replacement therapy do not tend to develop dementia at the same rate as women who do not do hormone replacement therapy. That might actually be a reason to do hormone replacement therapy. We mentioned cholesterol when we talked about vascular dementia, high amino acid factors, diabetes, social isolation, not engaging in brain activities. We need to be keeping our brain active, not doing the same things every day, not just sitting in front of the TV every day. Someone who's been diagnosed with mild cognitive impairment, typically about 40% of those people within 3 years, it will become full-blown dementia. Someone who has a poor diet, has had a traumatic brain injury, and here's a new one that's been added to the list, air pollution. And I made myself a note on air pollution. Let me find that real quick. The relationship between air pollution and dementia is still unclear. However, it is estimated that those living close to busy roads have a higher risk of dementia because they may be exposed to higher levels of air pollution from vehicle emissions. Air pollution, which tells us that are we moving closer to that? Here's why some people develop it and some people don't. So diagnosis of dementia. Let's move to this. We always start, mentioned this before, we always start at the primary care physician. We want to start at the primary care physician because, like I said earlier, we want to rule out all of those other things that can cause memory loss. Because if they are just having memory loss without having any of those other issues with judgment, personality changes, language changes, communication, it may be something else. Now, that doctor should talk to the patient and to the care partner. They should do a family history, a medical history, a medication review in case it is a medication interaction. We've got to be really honest when we're in there and we're talking to these doctors, because if somebody is mixing medications with alcohol, that could show up as memory loss. They should do a physical exam, an MMSE, which is a mental status exam, that mini mental, lab work, a lot of lab work, and they may even go ahead and order some imaging tests. Typically, you're then referred to a neurologist or a geriatrician. Same thing as the primary care physician, but they specialize in their field. They're going to order either some of those same tests. They may do a lumbar puncture, test for some proteins. They may do an MRI. They may do a CT. They may do a PET scan. They may do an EEG. You may also go to a neuropsychologist where they may do that neuropsych testing, and they may test their orientation, their memory, attention, verbal and written commands, and other cognitive abilities. Some of these tests can last for hours. Also, families sometimes will decide not to put their loved ones through the neuropsych testing, especially if they are, let's say they're 85 years old and they're developing these. They're already over life expectancy. Right now, today in the United States, life expectancy is 76 for men and 81 for women. I know that's low. It dropped for the last 2 years. It was 81 for men and 86 for women. But now it's 76 for men, 81 for women. So let's say that somebody's 85 years old and they're developing these symptoms. Just how much am I going to put them through? But if somebody's 58 years old and they're developing these symptoms, I may go ahead and go through all of this testing. Now let's look at treatments, because you heard me say there's no cure, but there are treatments for symptoms. There are medicines used to treat symptoms, to improve mental function, mood, and behaviors or expressions. Another thing that we have to start talking about early is palliative care, because we're not going to be curative. So we have to shift our mind to comfort. And that's hard. We're used to, we're sick, let's go to the doctor, let's get something and fix this. And with dementia, we can't. It's terminal illness. So we have to shift our focus as caregivers to body, mind, spirit, and quality of life. Now, some of the medications that are used, some of these you've heard of over and over again: Aricept, Namenda, Exelon. This first group here are used to treat confusion. They work in some people, they don't work in others. In some people, they have such bad gastrointestinal issues that they can't take them. The majority of the ones that they call memory meds, we know tend to work 18 to 24, 36 months. But I've known people who've been on them for years. But for the most part, we think they work anywhere between 18 and 36 months. Now, some people will use antipsychotics, and those are used to treat mood disorders, irritability, anxiety, depression, hallucinations, delusions, aggression, agitation, hostility, uncooperativeness, and agitation. But what will happen is that the doctor will prescribe something like Seroquel, and boy, the families will get on Dr. Google in a hurry. They'll get on Google and they'll start reading about somebody over the age of 65 shouldn't be. But Seroquel is one of the ones that's used the most often in people with dementia, with good results. Antidepressants. Earlier in the disease, a lot of folks are on antidepressants because they are depressed. They understand, they know their body's changing, something's wrong. Later in the disease, a lot of folks are on an antidepressant simply because of the brain chemistry changes that are happening because of that brain failing. There's a medication that's listed there under antidepressants called Remeron, and it actually is an appetite stimulant. And many folks will go on that at some point because with this disease, A lot of times they'll either forget that they ate or they don't want to eat. They're not feeling hungry and they'll stop eating or they'll stop losing weight. And so we'll do something to stimulate their appetite, knowing that eventually with this disease, because it's that brain that's dying and that brain controls everything, that they're going to stop eating. They're going to start losing weight. A person with dementia does not die because they stop eating. They stop eating because they're dying. And in most people with dementia, the digestive system is the first system that does shut down. There's medications there that are used for anxiety, restlessness, verbally disruptive behaviors, and resistance. And then there's mood stabilizers. And those of you who follow the news, here's a brand new slide because we have a brand new medication that's out. Now, this is new. I have some things in bold, dark print that we need to make sure and see. First, I want us to look at, and I took this straight off of the Alzheimer's Association website, which is a fantastic website, alz.org. But I want you to see what this does. And I'm not going to read this whole thing to you. I want to just point out a few things. For treatment of early Alzheimer's disease with confirmation of elevated amyloid beta. Okay. Notice it then says it's the first traditional approval of an Alzheimer's treatment that changes the underlying course of the disease because it targets that amyloid beta. Now, what they're finding in phase 3 clinical trials is that the new medication delayed cognitive decline by 5.3 months compared to a placebo, and that was after 18 months of treatment. It is administered twice a month through an IV infusion. You've got to be able to do an IV infusion. And then here's a really important factor. The side effects that they have had the most often are brain swelling and brain bleeds. And it says it usually resolves over time. It's brand new. That's good that we have something that's new. Not so good that the side effects can be a brain bleed or brain swelling. It does say it resolves over time, usually. So we'll see where they go with this. We're going to hope and pray that we are on track to coming out with those medications that we need. Other things that we can do to treat dementia, treat the symptoms of dementia. We're going to do anything and everything to enhance quality of life. And part of that is therapy. Physical therapy, occupational therapy, speech therapy, and music therapy. And if you're not familiar with them, I've just put a brief description of each of them. I have seen therapy work miracles. Here at the West Center, we have our own therapy department where everybody who works on the therapy team is specially trained in dementia care. Because think about what's happening with physical therapy. They are able to go in and tap into procedural memory and muscle memory because those are long-term memories. Most all of therapy is tapping into long-term memories. They just have to know how to do it. And traditional places, many times, will say the person with dementia is non-compliant and they'll dismiss them from their service. You've got to get therapists who know how to work with people with dementia. Because look with physical therapy, reduction in fall risk, they're going to start to have a lot of falls because we haven't always been walking and they're going back to who they originally were. Eventually, they're going to stop walking. But if we can help with that fall risk and increase circulation, which helps with cognition, muscle tone, flexibility, strength, balance, mobility, occupational therapy. This is, I don't know if I'll say this is my favorite. I think each of them are my favorite. Retaining existing functions for as long as possible, dignity, independence, quality of life. It allows them to continue to feed themselves, It allows them to continue to assist with them getting dressed, brushing their teeth, combing their hair, toileting. We all want that for our loved ones and for our clients. An occupational therapist can also come into our homes and help us adapt the home to make it safer. Talk about grab bars, bath chairs, adaptive eating utensils, and other modifications. And I've put a website there also that can help with that. Speech therapy. Speech therapy is who we call when we're needing those swallow tests done, because eventually we're going to have issues with swallowing, because what controls that? The brain does. They stimulate cognitive ability. They know how to use memory aids. And then they are the ones who can help with management of eating, drinking, and swallowing. They can come in and do a swallow test, and they may change their diet. They may put them on a thickened liquids, something that helps them maintain quality of life, dignity, independence. And music therapy. There's an awful lot of study behind music therapy and dementia. The side of the brain that is the rhythmic side of the brain is the right side, and it remains so much longer than the left side. And music can be used as a mood stabilizer. It helps us connect with people with dementia. It helps us stay social. It can reduce isolation. People will dance and they will exercise. I was in our day program earlier, and just by simply putting on an Elvis CD, there were people dancing around just because there was music on. It makes a difference. Other interventions, we're doing it right now. You're doing it right now. Education. We always say education is the number one way that we treat dementia. We have to educate ourselves, whether we're a professional, whether we're a family caregiver. We've got to understand this disease process, how to change the environment, how to change the way that we approach our loved one or our clients or our patients or our residents. Learning how to monitor personal comfort and how to look at our loved one, our clients, residents, patients, and when they can no longer tell us that they're in pain or they're hungry or thirsty, how do we figure it out? And we're not being confrontational. And we're using validation therapy. And we look past the words, past those behaviors, and look at the feelings and the emotions, because we know those are still there, because we know the amygdala remains intact. We use compassion. We stay connected. Boy, are we flexible. And then we have 4 things that we use for redirection. Food is number 1, the sweeter the better. Music is number 2. Food and music together are fantastic. Animals and children. And if you don't have real animals or real children, YouTube is our friend. You type in funny animal videos or children laughing videos. How do you help somebody with dementia? You keep building your skills about dementia. You keep educating yourself about dementia. And you focus on their quality of life. And this is their journey. We're on it with them, but it's their journey. We have to go to their world. They can't come to ours. They're never giving us a hard time. They're having a hard time. If we have to go back and look at that picture of that brain going down to 1 pound over and over again, then that's what we have to do. Now, also as caregivers, we've got to take care of ourselves, because if we're not taking care of ourselves, we can't take care of somebody else. Some places you can go for help: the Alzheimer's Association, Teepa Snow's website. If you have never watched Teepa Snow, she's got some fantastic videos on YouTube. The Alzheimer's Society, which is out of the UK, the North Central Texas Area Agency on Aging, and of course us here at the James L. West Center. Here are some other resources. I wanted to make sure and leave you with plenty of resources. A lot of this is where I got the statistics for this part of the presentation. And then there's just some really interesting articles and information out right now. I wanted to leave a little bit of time here at the end. Let me see, Marty and Jamie are probably about to hop back on to talk about CEs again. And then I'll look and see if we have any questions in the chat.
Great, that's outstanding. Jamie, go ahead whenever you're ready.
Absolutely. Please remember that if you are wanting CE credit, you must complete our SurveyMonkey evaluation that will go out in the follow-up email. We do ask that everybody completes the evaluation. We do appreciate and need your feedback on our programs. And the survey will close in about a little over a week.
Great. In addition to the SurveyMonkey, as you close out of Zoom today, you should get the opportunity to go and open up a Google survey. That is for our funding to help us report back on the goals and objectives that we set out when we applied for the funding to put on these webinars. So if you would, we ask that you will do both. That would be very helpful. But just so you know, the SurveyMonkey is required for the CEUs. I want to reiterate one thing that Holly said, and I know there's a lot of great stuff, but one important piece is for us not to be intimidated or have the stigma to not talk to our doctors about depression and those kind of things. So many of us were brought up in a time when it was something that you didn't talk about. We weren't supposed to talk about it. It's it's humiliating, it's embarrassing, but they can't fix it if you don't tell them about it.
Right.
Go ahead, Holly.
No, I am agreeing with you 100%. That is true. We have to talk about it. And the good thing is we do have, with dementia and depression, we've got celebrities now that are starting to talk about it and own. Michael Phelps has been very forthcoming with his depression. Lady Gaga talks about her depression. You know, when people come out and they start talking about going through it themselves, it's almost like it normalizes it for us. We've got Bruce Willis's family talking about dementia. Jack Hanna's family is talking about dementia. I heard of another one just in the last 48 hours. Oh, Jack Nicholson has dementia. You know, people are talking about dementia now so that it doesn't have to have that stigma to it. I did want to make sure and show this slide before I start going back through the questions that we're going to do next month, managing physical and emotional expressions. Notice we said instead of behaviors in dementia.
And I guarantee you that will be a huge topic. I get that one a lot. People asking for that.
Let me pull up question. Jamie, I don't know, were you able to answer any?
There was a question in the QA for vascular dementia. Can it occur at any age?
Yes, vascular dementia can occur at any age. That's why we do see people that are so young many times getting diagnosed. The youngest I've ever heard of getting diagnosed was 28 years old. That was actually in McKinney, Texas, where someone was diagnosed at 28. Now, that doesn't mean that every single person that has a TIA is going to have vascular dementia. Please don't take that away. But it's sure something for us to be thinking about and to know. And then when we look at all those other symptoms and go, wait a minute, this is so much more than memory loss.
And there was two more questions in the Q&A so far. Where can we get information on community support / services available for people with dementia, options for care, etc.? I would say,
Sure.
I know you had the resource slides in
Yeah.
your presentation, and I would say Marty would be a great person to answer that. It depends on where you're at.
I will tell you that in Texas, there's a statewide Aging and Disability Resource Center line, and there's also a statewide Area Agency on Aging phone number. Both of those, you go through, you answer a few questions about where you're located, and they would literally just transfer the call to the local Area Agency on Aging or local Aging and Disability Resource Center. And those are across the state. but they're mandated by Congress in the 1960s with the Older Americans Act. They are mandated to cover every county of the country. So wherever you are, there's an area agency on aging, and the area agency on aging may be called something a little bit different. But in general, it's the area agency on aging. It may be called aging services, but you have one if you're located in the U.S. And you can always email me if you can't find it, and we can try to get you to wherever you need to go.
Good. And you have access to the Alzheimer's Association wherever you are in the United States. Now in the UK, it's the Alzheimer's Society. If you call the 800 number I put on there, alz.org, the 800 number, you typically get somebody who's your local chapter during 9 to 5 business hours, or it will route you, I believe it's to Chicago, and you get a dementia care specialist on the phone 24 hours a day. Anybody can call that number anytime. And so if you're needing resources, you can say, I'm in such and such New Mexico, and and they can get you list of physicians, list of elder care attorneys, list of adult day programs, list of licensed long-term care facilities and assisted livings through your Alzheimer's Association. And it's just like Marty was saying, with the local area agency on aging, you have local Alzheimer's associations. Now, it may be a long way from you, but they cover your area.
Also, I didn't add that those phone numbers for the statewide Texas numbers will both are in my address bar at the bottom of every email I send out. But I will also try to get from Holly or Jamie the national numbers for the Alzheimer's Association and include those in the follow-up email today. I will also include Tippa Snow's links to her videos that Holly's mentioned several times in her presentations.
And Holly, there was another question. My father had been diagnosed with medically induced dementia due to being on antipsychotic meds and depression. So treated depression also has a risk. Is this common? Any other info?
Medically induced dementia due to being on antipsychotic meds and depression. So treated depression. I know of one other person that actually it has a very similar story to that, and they were somebody who was in Vietnam. So they had also had Agent Orange exposure, which is a very, very high risk for developing dementia as well. But they had been on antipsychotics for 50 plus years, and they have been told that that was one of the reasons that somebody had that diagnosis from the antipsychotics more so than the antidepressant. So I don't know that it's that common, but absolutely. But medication induced, yes, just like there's drug induced, there's alcohol induced. Absolutely. And that's where we also want to, and we may not always know, especially if it was a parent, were they taking it correctly over the years? What were they taking it in a combination with? Was it when we even knew that there was drug interaction for different types of medications? Were they mixing it with alcohol? Sometimes we just don't know. Lots of great questions.
There's a really good question from Chris in the chat about working at the psychiatric ER at the Dallas County Hospital, and I don't know if you've seen that, but it was at 1:26 p.m.
I see it,
and I don't believe you've answered it yet, but you may have. I'm sorry. Just please note that also in my signature, in my emails, is also the link to our YouTube channel. And all of these webinars that we've done are on the YouTube channel, and you can access them anytime from anywhere that you have the internet. They're free of charge. And in most of the ones, at least in the last couple of years, if you go down in the notes at the bottom, there will also be the link for the slides to download the slides and take notes while you're watching the videos.
Yeah, I saw this from Chris. Jamie, I don't know if you saw it. How do I properly advocate for something that my team is specifically told is not our team's issue? I feel your pain. I can tell you what I know. One I personally know someone who is is a nurse in Dallas who went through this journey with her mother, and she has just used her education and her knowledge to then use it with patients. And she said it's been amazing how now people come to her and go, how is it that you can get them to, we're getting ready to restrain them, but you're able to because of the skills that she has. And it's everybody's problem. Oh, I hate that. And I'm so sorry you're going through that. One thing that I do tell families whenever they're having to call, like for an officer, if you ever get to the point that you do have to call the police, always ask for a mental health officer. In most big cities now, they do have mental health officers. So ask if you're having to do that for the mental health officer. Jamie, anything to add? I know that is so frustrating.
I mean, you're right. They're just going to get back into the hospital, right?
Of course.
Which y'all are trying to avoid those readmissions. But if you can maybe ask for a geriatric consult or a neurology consult, or if there's a department in your at the county hospital where they could go to other than the ER, if y'all have already excluded that diagnosis, and then just ask them to go to the clinic over here or the geriatric clinic, or really partner with your community-based organizations and say, we might not be able to help you right now, but we really encourage you to call this organization or go here. Would be
the
my
other
best.
thing is if you can encourage them to listen to some of these webinars. I mean, some of these webinars, I think that we find incredibly helpful. And again, they're accessible online, recorded, most of them. And this one we did about a year and a half ago, and we still had nearly 500 people sign up for it today.
Great. Well, we are right at time. I know some of you
Great.
may still have questions. You've got mine, Marty's, and Jamie's information. You can email us at any time. You can call us. We have a YouTube channel as well where you can go and you can find programs that we've done in the past here at the West Center. And then Jamie just put up the link for the ones that Marty was talking about earlier. So we appreciate all of you being here. If we did not get to your question, I'm so sorry. Please email us. We will get right back with you.
And the website link to the James L. West Center is also in all of the follow-up emails for the webinars we partner with them on. So look for our email, our follow-up email. Jamie, Holly, once again, incredible job. Thank you all for joining us. Hopefully you can help us spread the word so we can help even more people, but you all have a wonderful day.
Thank you. Bye-bye.
Bye-bye.